Hey guys, good evening and welcome to Cozy Talks Live. I have some new friends with me this evening and I've been waiting a really long time for tonight's guest. So let me just go ahead and welcome Ginny Thomas and her prosthetist, Scott Annis. Guys, welcome aboard the Cozy Talks hot seat. Thank you for joining us this evening.
Thanks for having us.
All right, so let's get our shout outs here. We've got Tom coming in from Maryland. We got Scott with West Virginia with his cold water. Emily from Central PA, Diet Coke, nothing fancy, and her prosthesis fitting tomorrow. Yes, Emily, let's get that right. We got Michelle right there. There's my girl. There's my fellow PT right there. We got Dave coming in as well. We've got Pam coming in from New York. Guys, if you're new to the show, part of the ritual is you got to let us know who you are, where you're from, and what is in your mug. And I am embarrassed to say that I brought water tonight to the show. So yeah, I'm in the doghouse. Yeah, okay. All right, we're all in the doghouse tonight. It looks like. Yep. All right, so guys, I need you guys to share with me what your better drinks are this evening. We got Steven coming in from Michigan, drinking water both. So that's just how we're going to roll tonight. We got Glenn on board. Glenn is no stranger to this show, guys. He was telling us his story about osseointegration a few weeks ago. And we've got Matt Whitaker coming in from Fort Wayne, Indiana. And to my Instagram people, I have not forgotten about you. I see Fred is on board. We got Ronnie on board too. Man, Ronnie, it's good to see you. It's about time you came on the show. Let's hear for it. We got Mr. RoboCop Leg. And I'm not going to even try to pronounce this other handle because it's just very, very interesting. El Chingon there is also there on board. So guys, Instagram, thank you for joining on board this evening. We got Stacy from Michigan. Diet Coke just walked in from work. Well, we are happy that you are here with us after work. So sit back and take a break. We've got Kim and Carol coming in as well. And she's drinking her coffee right there. We got Van Gregory from Texas, Jerry Ann. I got all my peeps here on board. I'm loving this. All right, guys, we got a nice crew. So we are officially going to get started because we have a lot to cover on tonight's show. So for those of you who are joining us for the first time, welcome. My name is Cozy Belloso. I'm a physical therapist here in Tampa, Florida, very hot, sticky Tampa, Florida. And I've been a PT now for 23 years, and my passion is working with the limb loss community. And tonight's show is being graciously sponsored by Integrum. They are the makers of the Oprah implant system. You may have heard of it referred to as osseointegration, osseo-anchored, bone-anchored. We got all sorts of fun names for this process. And with us tonight is one of their lovely ambassadors, Ginny Thomas. Ginny and I have been following each other on Instagram for quite some time. And I'm so excited that you are finally able to be on the show. And then Scott, there's not many prosthetists out there who are experts on alignment with osseointegration. So thank you again for coming on this evening to share with us your expertise.
Of course.
All right, guys. So the purpose of tonight's show is we're going to be talking about alignment. That is something that you hear me talk about on the show as being a contributor to sometimes when things go wrong with your prosthesis, with your socket, for those of you who are wearing a socket. So part of tonight is going to be talking to you about just the basics of alignment, whether you use a traditional socket or if you are an osseointegration user, okay? And then we're going to get into a little more of the nitty-gritty of what makes osseointegration different when it comes to alignment, the pros and the cons each way. So a lot of good information. We've got a lot of good visuals. You know, I like to get fancy, and I've got my pictures up and ready to go. All right, so let's get started. But now I'm going to go ahead and quiet myself for a minute, and we're going to listen to Ginny's story because she's much more interesting to listen to. So Ginny, I'm going to let you take it away.
Well, thank you very much. I am Ginny Thomas from Montgomery, Alabama. I was involved in a motorcycle wreck in 2012 and broke every bone in my right leg in several places and did not amputate immediately. I actually passed out in the ambulance, and everybody else around me made the decision to try to save my leg. I'd also lost my husband in the wreck, and I was conscious right after, and I saw everything, so I knew that he was gone. But nobody else knew that I knew that he was gone. So everyone else made the decision to try to save my leg because they did not want me to wake up and have to tell me that I'd lost my husband and my leg. So the surgeon said it would take a lot of work, but he thought I had a 60% chance of being functional with the leg again. So I did salvage surgeries for 3 years before ultimately deciding to amputate above the knee in 2015. And did okay with a socket for a little while, and then had some issues, which we can get into later, and eventually made the decision to opt for a bone-anchored prosthesis with the Oprah implant system after a lot of research. But been very happy with this. I've had it since January of 2022, so just over 3 years, rocking right along.
And it's like, I mean, I've been following your story now for the past couple of years, and it's interesting because when you and I first spoke, you mentioned that your surgeon at the time when you brought the information to your surgeon, they really didn't know much about the procedure themselves.
Yeah, and it's been a lesson in learning to advocate for myself and getting in touch with the right people who were on the same wavelength as me in order to get things done. Scott, my prosthetist, has been a huge advocate for me along the way, has helped me in getting set up with not only the surgical team, but a physical therapy team afterwards. Finding a physical therapist who had some experience with this was difficult, especially where I live. So the network is really paramount.
Yes. And then it's not been smooth sailing. I mean, there's been ups and downs with everything, and you've been very
Sure.
open with sharing that.
I've had some setbacks with neuromas, soft tissue problems. I've been fortunate to not have any infection, but I've had other issues along the way. I think the biggest issue I found was not following the rules, and then I tore the labrum in my hip when I stepped in a hole at the beach. But
Yeah.
I learned, and now I get to help other people learn through my mistakes.
Yes, you do. No, and with every setback you've had, you've always said, I don't regret this decision.
Yeah.
Regret
Come
this.
back stronger every time. It's all good.
What is it that you like most about OI compared to when you were using a traditional socket? You're like, where do I begin?
Yeah, I think the number one thing is just not dealing with sweat issues anymore. The sweat issues would then lead to chafing issues on my limb, and not having to deal with that has been huge. Being able to do an entire hot yoga session and knowing that my leg isn't going to fall off or even get loose or twist around, that's huge. Love that part.
Yep. And then Scott, we got to get lots more people jumped on. So we got to give some more shout outs. We got Harsh coming in from Richmond. Let's see. We got Rochelle says, hi to Ginny and Scott. This is near and dear to my heart as a Baca OI, rocking my orange and drinking orange cream soda. Thanks for joining in. We've got Lisa on board and Earl from California. Yes. And Lisa saying Oprah is a beautiful gift. Yes. And folks, we've done quite a few shows, on Cozy Talks about OI over the past couple of years, and even back before they were FDA approved, when they were still in the investigational device exemption part of the phase. And it had so much promise even back then. And we've had so many beautiful stories of folks who were candidates for this surgery and how it changed their lives dramatically. So Scott, you're just way too quiet. So we just got to kind of bring you out just a little bit here, right? You can't let these two women just rule the roost here. So tell us a little bit about yourself, your life as a prosthetist, and what brought you to the field.
Sure. Yeah. So first of all, thanks for having me on, and thanks, Ginny, for all the advice and kind of patience you've had with me along the way as we've learned together. It's been a really rewarding process going through this with you, and I've learned a lot and been able to help a lot of other people through you. So thank you guys. So my name's Scott Annis. I'm a certified prosthetist orthotist. I am based in Atlanta, Georgia. I work for ProCare Autobot Care, and I've been with my company since 2019, so about 6 years now. My journey in the field began in 2016 formally, and I was at a big hospital institution in San Francisco, the University of California, San Francisco. So UCSF is what we call it, and that was my introduction into the field and also my introduction into osseointegration. So there, we were seeing patients pretty early on in the grand scheme of things in the U.S. It wasn't a very common practice. It was kind of these one-off exemptions or people traveling out of the country to get it or getting it done through a Department of Defense institution. So I didn't know much about osseointegration. I'd heard about it in school studying and kind of knew what it was, but I really started to learn about it in my residency there and working with Matthew Garibaldi there, who's an awesome prosthetist and a mentor of mine. And he kind of let me dive in and learn and ask questions and push me to think about things that I hadn't thought about. And it was a really cool experience during my residency to work with these patients. And it made me realize that if you have a really good care team and you have a good candidate for this, that the outcome is really great. And it was really cool to see. So that sparked my passion for it. And I got to work out there for about 4 years before I moved to Atlanta, and I got to see a lot of patients through the process kind of long term. And so that was really valuable for my experience to come back to Atlanta with. Came to Atlanta, and when I moved back, there was no one in Atlanta providing osseointegration. So I was kind of, it was kind of something I was passionate about, talking with Matthew about, talking with some other prosthetists about, to try to stay on top of things. And it wasn't too long after we kind of got into Atlanta and started practicing that Emory here in Atlanta started offering it. So that was just a huge kind of moment for me in my career, an opportunity to kind of get in there and talk to patients and advocate for them and educate them on the option, and have something local that I could provide to them if they needed it. And so since then, we've had a good amount of patients either through Emory, or even some patients have traveled to other hospitals to get osseointegration, and have seen them through the journey. And it's been something I've continued to be very passionate about, and I've enjoyed it. And so it's kind of my experience with it.
And that's pretty amazing that you were able to get in so early in your career. So really kind of growing up in your profession with both traditional and OI options. That's a very unique opportunity. Lisa says, I went from straight amputation to OI, never had the socket. Can't imagine dealing with the socket. Love you, Jenny. Josh is saying, for those with socket problems, this has to be amazing. And you're absolutely right, Josh. So for those of you who have never seen this show, because heaven knows we talk about OI a lot on this show, the brief overview is, with osseointegration, it basically is the ability of the body to fuse with a metal implant, specifically an implant made from titanium. And it comes from the dental implants. That technology was then carried on by Dr. Ricard Brandemark. So basically with the Oprah implant system, it's a two-part procedure. The first part, they implant the fixture into the femur. Right now in the US, it's FDA approved for above the knee amputees only at the moment. So they'll put it into the femur, close everything up, let the person heal from anywhere from 3 to 6 months, depending on the individual. And then in the second surgery, the surgeon will typically create an opening. And from there, the abutment comes out. So that's like the little metal rod that you'll see sticking out that attaches directly to the prosthesis. And we have a beautiful picture here of Jenny that I'm going to show. So you guys can see right there where the abutment is coming out of the opening in the bottom of her leg. And then there's the picture. So as you can see, the prosthesis attaches directly to Jenny's leg without the use of a socket. So Josh, you're absolutely right. Basically, all the issues that you have related to a socket are gone. It's not to say that there aren't any other things that you have to deal with. And it's like, even Kurt, who's been on the show several times, he's an expert prosthetist as well, will say, well, you are giving up the socket problems, but you also have to take on responsibility for other things that go on with OI. So Jenny, what would you say are some of the responsibilities that you have now being an OI user?
You got to make sure you keep the exit site clean. I mean, hygiene is important, and I shower every day anyway, but gotta take care to scrub that exit site and keep it clean. You also have to be aware of what bodies of water you're swimming in. If you're someone who loves the water like me, you have to take precautions and make sure you're either wearing a covering over it or you're applying Vaseline around that aperture as well, just to act as a barrier and keep things out. And then clean it really, really well afterwards. That's going to be huge.
And guys, we did a huge show with Dr. Forsberg on how to keep the aperture site clean. And Glenn was very gracious enough to come on the show and share some of his examples as well. So let's see. Carol says, hi, Scott. My surgery was at UCSF in the first group. So guys, before we progress any further, I am late doing my first giveaway, which is very shameful. All right. Because I'm getting fancy now with the QR codes, guys. I want to see you guys clicking. And by the way, my streaming software tells me how many people clicked on my QR code. So if y'all don't click, I'm going to know about it. And I'm going to have some issues. So guys, click on the QR code. It's going to take you. See, even Ginny's doing it. It's going to take you to the Integrum YouTube channel. I got to sit this way because it's covering my face. Subscribe to the YouTube channel, and also you'll get a chance to listen to Ginny's story again. If you look on their YouTube channel, guys, thank you. Somebody is scanning the QR code. Thank you, guys. All right, let's keep it going, guys. when you go to their YouTube channel, you're going to see a lot of the different stories. And truly, guys, it's not all roses and rainbows for folks that you see there. You see them being very active. Obviously, Jenny is incredibly active individual and does everything. But she's had her journey to get there, and she's had to overcome her fair share of obstacles to get there. So what I love about these stories is that they share the truth about it. So guys, go ahead, subscribe to that YouTube channel. I'm going to leave this up for another minute, so keep clicking. All right. And then we're going to get started on the meat of this talk. So let's talk a little bit about alignment. So, the basic definition of alignment is how the socket is positioned relative to the prosthesis. Okay. And guys, we see alignment everywhere in the world. We see it in mechanics. We see it in carpentry. We see it in all sorts of trade around the world. So it's pretty easy to understand, like the way the human body is aligned in a very particular way. Thank you guys for clicking on that QR code. All right. I'm going to take it down in 5, 4, come on, 3, let's go. Come on, go. 2, 1. And okay, now I got to take it off. All right. So when it comes to alignment, we're having to replace what Mother Nature originally created. So we're going to use Bob here because he's always my reluctant model here. Okay. So as you can see, even with Bob, he's got pretty decent alignment, right? You can see that our femurs are kind of meant to go in just a little bit. I'm going to exaggerate it here with Bob, right? It's not just a straight up and down alignment. We've got a lot of angles. We have a lot of lever arms all throughout our human body. Okay. So Scott, how do you explain alignment?
Yeah, no, I think that's a good overview. I try to break it down and keep it as simple as possible. If we're talking about a socketed conventional prosthesis, it's just simply that relationship between the socket and then the components that are beneath that. So if it's someone that has a transfemoral amputation, it's going to be the socket in relation to the knee joint and the foot and ankle complex. So it's just establishing a relationship between those parts and pieces. And it's something that we can manipulate, and that's something we pay a lot of attention to make sure that we have things in a biomechanically sound position so that we can minimize energy costs and improve gait efficiency. So there's alignment can get very complicated, but simply it's where are the parts and pieces of the prosthesis in relation to each other. And there's certain things that we're looking for to make sure that, first of all, especially for someone that's new, that you're stable and that you're safe and that the components are going to kind of work how they're designed to work to keep you safe and stable.
And that's a good point that you bring up, is you brought it up in just a few minutes ago, was about how the purpose of alignment is to help with efficiency. Okay, because guys, you're transferring your weight. Ideally, you're supposed to be transferring your weight into that socket or into that prosthetic leg. And if things are not aligned properly, that weight's not going to get transferred properly. And then it's going to go up the chain and cause some really serious issues with back pain, hip pain, knee pain, all sorts of things going on. One visual. Oh, sorry, guys. Thank you, Integram. Okay, so for those of you who are not able to do the QR code, Jamie went ahead and posted the link, so you guys can click on that link and subscribe to their YouTube channel that way. We'll announce that we'll give you guys another minute to do that. So the kind of visualization I like to give people is, how they tell you can move the world if you had a long enough stick, right? When you're trying to kind of move something, that's kind of how alignment works with the human body. Is you have to adjust those levers, you have to adjust the angles. So you can either make it really easy to move the human body, or it can be really hard if things are not done well. And Jenny, I know you've gone through a lot of different alignment changes and evolution. And so how do you feel when your alignment is not where it needs to be?
When it's not right, I feel like I have a lot of trouble making my prosthesis work. Like I have more difficulty making the knee bend. I feel like it takes a lot more energy just to take a step. And normally when I start feeling those things, that's when I call Scott and I say, hey, things have changed. I've either gotten more flexible or less flexible, and we need to make a change.
Yes. And that's something that we're going to be talking about, because that's one of the big differences between someone who has OI and someone who's using a traditional socket. Okay. Typically when someone has a traditional socket, and I know Scott, you're definitely going to be able to chime in on this one, you're going back to the prosthetist to adjust the socket because your limb volume is changing. With OI, your alignment starts to change. And that's actually a really, really good thing. And we're going to get a little bit more into the why behind that. In the meantime, Stacy says daily socket alignment, even when everything was set up perfectly with my prosthetist, was misery before osseointegration. I was constantly adjusting it throughout the day. And it's one of those things you just forget about now. Sonia says, hi, Ginny. I was the first person to have OI done at the U of L University Medical Center. After 7 years of constantly losing volume, this was a perfect fit for me. And Janice says that her husband is scheduled on May 21st for osseointegration. So, Scott, what can you tell us a little bit about, is alignment the same for everyone? I'm just going to throw that one at you.
Yeah, so definitely not. Everything with prosthetics, almost every single thing it depends on the patient, because everyone's so unique and so different. And so when I start with alignment, whether it's an osseointegration situation or a conventional socket, I try to get familiar with the body and the position that they're comfortable in. And so there's a lot of detail and a lot of things that we're looking for and cueing to try to figure out where that limb just naturally wants to rest, where it wants to be, and starting to evaluate their mobility, the range of motion they have, the natural positions. We can look at that, and it gives us a clue of where it wants to be, and then we have to mimic that when we have the prosthesis. And so when there's a socket involved, it's a little bit different, and we have to be mindful of making sure that the socket's fitting appropriately before we start changing alignment things, and make sure that the socket fits good first. But once we move to that alignment phase, the first things we're kind of looking at are what's their range of motion in their hip, especially for an above the knee patient, and where does the prosthesis need to be in relation to where their limb is. So, for instance, if someone has a hip flexion contracture, which is a very common presentation that we see with new patients that have been sitting for a period of time in a chair, or just not walking, and their hip starts to get tight, those hip flexor muscles just biomechanically are positioned to where they can kind of take over and move the hip into flexion, which means up. And so when that happens, we have to do certain things to our socket to accommodate for that and get the knee in a position to where it's stable. And so when you have a socket and an OI patient, the first difference that you're going to have is you can't move your prosthetic components and attach it in a different spot. It's attached to where that abutment is coming out. And so that's the biggest difference when you're starting to look at alignment is you really don't have a way to shift and move things in the same way. So you have to think about first connecting the patient with physical therapists and saying, hey, we really need, before you even get the surgery, we need to have you start working on these things. It looks like your hips are a little bit tight, and I can give them some tips and advice, but really going to physical therapy and getting involved early is huge for starting off in a good spot with osseointegration. It's just as important with the socket, but we can fudge it with the socket. We have a little bit more capability to move things around in relation to the socket. So that's a really important distinction, I think.
Yeah. So let's talk a little bit about how the alignment works. And you guys know I like to give you, I don't like to, sugarcoat it for you or water it down. I'm going to give you some of the vocabulary that you might be hearing your prosthetist using. So how exactly do they even put the leg together, and what's taken into consideration? It's actually kind of 3 basic phases of alignment. The first one's called bench alignment. And it literally is when they are putting the prosthesis together. I like to think of it as like the Mr. Potato Head, where they have to put this piece and the knee piece and the foot piece and the pylon. And it's done according to the manufacturer's specifications. And some people are just like, well, doesn't a prosthetist know how to put a leg together? Why do they have to read IKEA instructions? And it's basically because each prosthetic knee and each prosthetic foot has its unique center in there. So inside of that knee, where all the gears are turning, where all the magic is happening, where all that rotation is going on, it's only known to the manufacturer and the engineers who created that foot. So that's why the prosthetist will follow the directions on how to align it. And it's only a difference of a few millimeters here and there, but those millimeters make a big difference. So once the prosthetist has put the leg together, they call you in, they put your leg on, and they have you stand. And then they do what's called static alignment. And exactly that. They will take a look at you in the different planes. And I got a fancy picture and everything. Okay. So they're going to look at you in 3 different ways. Look at you from the front, and we call that the frontal plane, and from the back. Then they look at you from the side, we call that the sagittal plane. And then they're going to look at you from the head down, almost like a bird's eye view. And that's the transverse plane. And they're looking at how your joints are aligned in all of these different planes and then coordinating it all together. And if it sounds a little hairy, that's because it is. Right? So first you align a person in each of these planes, but a person just doesn't move in like little planes like this unless you're a video game, right? A person is moving in all sorts of different combinations of these planes. Okay. So, but first they start in these planes, and then they have the person walk and take a few steps in the parallel bars, and they call that dynamic alignment. And that's when all the fun really begins, right? Because you think you have alignment done with the person standing, and then they start to move. So, Ginny, I know you can probably appreciate how standing patiently in those parallel bars, right? Waiting for the alignment, for Scott to do the alignment statically, and then walking. So have you ever had the experience where you guys thought you had it right and static, and then you started moving and realized, nope, didn't work. We got to change some more. Yeah. So tell us about that, Jenny.
It still happens. I'm that patient who wants to go in for adjustments every couple of months, just because I think you can feel so much more with osseointegration. So even the tiniest change makes a difference. So I'm constantly going over there, and we'll make a change one way or the other. And I'll take a few steps, and instantly I'll go, oh, no, that doesn't feel right. So we stop right there, go ahead and change it back, maybe tweak it a different way, or only go a little bit, see if that's any different.
Yeah. And then a lot of it is, I know, Scott, when I have a patient who's talking to me and they're describing things to me, it's like we have to translate what they're saying. Like they feel like they're stepping in a hole, or they feel like they can't bend their knee, and going, okay, how does that translate into the angles and the alignment that might need to be tweaked?
Yeah,
right?
I mean, I'm lucky working with Jenny that she feels everything and describes it really well. And so for her, a lot of times I don't even need to see it. I can talk to her and I know kind of what I'm probably going to need to do. And then when I watch her walk, it's exactly what she's describing. And so in that way, it can be very simple, but alignment can be very challenging when you throw in joint laxity or different pathologies that cause tightness or spasticity, or and you start moving in a prosthesis and those things start to kind of affect your alignment. It can be something that we spend hours and hours fine tuning. And some people are very sensitive to their alignment and can feel very small turns of the screws and changes. And other people, especially I think sometimes for newer people, they're like, I don't know what this is supposed to feel like yet. And so I'm really relying on what I'm seeing visually. And so, but yeah, it's one of those things with osseointegration, and what Jenny's kind of getting at is that her range of motion and her ability to move her limb is always in a changing state. And if she's got some, like a surgery that she's had going on and she's healing from that, the alignment that we have her in before is not going to be optimal. And so she's great about coming in and getting those things worked out. And I think that's really important that you do that, or else you're gonna be compensating or dealing with something that you really don't have to. We can fix it.
So here's a quick COSI pull out, because I haven't heard from you guys in a while. I want you to put in the comments section, guys, especially if you're socket users. Do you know when your alignment is off? You can put yes or not really. And it's okay if you don't, guys, because sometimes people, like, again, a lot of my patients will come to me and they'll be like, this just something feels off. And especially folks who are new, that they're not sure if it's something to do with their socket. But if you guys let me know in the comment section, do you know when your alignment is off or not? Okay. Lisa says, all my friends here tonight. Hi, ladies. Thank you, Jeff. Thank you for being here with us this evening. All right, guys. So let's take a look. And again, guys, just because I'm a mechanics nerd and I like looking at this kind of stuff, we're going to put this picture up. Okay. So when your prosthetist, and we're going to change that and make it prettier. There we go. Well, not quite. Sorry, guys. So when your prosthetist and your physical therapist are taking a look at you, this is kind of what we're picturing in our brains. Okay. So when we're looking at you from the front or from the back, we are imagining this little dotted line. And that's basically the line of gravity. That's the Earth's gravity pulling onto your body. Okay. And basically all the curves that you have, like the curve in your neck, the curve in your back, the lower back, everything here, even the curves of your hips, it's the result of your body learning to work against gravity. Okay. And this is something kind of cool. I always thought was really cool. Like when you have a baby, what's the first thing that a baby learns how to do is it learns how to lift its head up, right? It's lifting its head up against gravity. And that is creating that curve right there in the neck. Isn't that cool? So as you, especially those of you who have kids and have seen your kids kind of grow up and go through the developmental stages, you see them basically fighting gravity to learn how to walk. And they look like little drunken toddlers when they're doing this, right? And then their body slowly takes this shape. Okay. So when a prosthetist and a PT are looking at you to check out your alignment, they're imagining this little line right here running up and down your body to see, okay, where do you fall in this line? If your knee joint is falling too far back, you're going to have a hard time bending your knee. Or the opposite, if your knee is going way too in front of that line, you're going to end up buckling that knee. And these are kind of some of the things that we start to look for. So let's see. Hang on, back to the comments. People are asking this here. So, we got a lot of responses here. So Linda says, oh yes, she can definitely tell when her alignment is off. Pam says yes. Lisa says yes. Stacy says yes. Marianne says I do. Stephen says no. Let's see. Earl says no idea. Carol says I know when mine is off. Emily says lots of things felt off. I couldn't tell you exactly what it was though. Mary says over the years, I know if it feels good, but describing it has always been hard for me. And that's something that definitely, guys, when I'm talking to my patients, I just tell them, don't try to put it into the technical terms. Just tell me what you feel, no matter how weird it sounds. And they'll say, I feel like I'm stepping in a hole and there's no hole here. And I go, nope, that's telling us something. So Scott, what are some of the things that you've heard from your patients when they're trying to describe something that you know is related to alignment?
Yeah. So, and again, there's some distinct differences between troubleshooting alignment with the socket versus osseointegration. And with osseointegration, I think you most of your patients have that enhanced feedback, and so they're feeling certain leans or pressures a little bit differently, and they're able to kind of describe that. A lot of times, if I'm evaluating a patient that has a socket and they're getting pressure in certain areas on their limb, that can tell me that there's an alignment change that needs to happen. So where there's redness or where there's irritation on their limb, that could be related to the angle of their socket. And so sometimes we're talking through, some skin irritation or discomfort in the socket, and that can dictate kind of what changes we are looking for and what we make and try. And they say, oh, that change you made, like, I like that. Let's do more of that. And then other things when patients are walking are just like the general, just overall smoothness. And so an experienced user is very in tune to how the foot is supposed to feel, their heel, their toe lever. There's a smooth transition from heel to toe. That your alignment's, more or less in a good spot in that kind of sideways plane that you were talking about, the sagittal plane. If they feel like there's a dead spot or they're having trouble rolling over the foot, you can kind of see those things, but sometimes you'll have someone that walks really well and you're not seeing that. And they're like, I do feel like I'm walking uphill or walking downhill, and you'll make a quarter of a turn of alignment change, which happens on the components of the prosthesis. And you make that change and they're like, that's it. And that's the spot. And so we're looking at patient feedback. We're looking at what the prosthesis is doing. If the prosthesis is leaning a certain way, we know what changes to make for that. If the knee is not swinging through smoothly, if there's what we call a whip, which is where the heel either goes out or in, we know that we need to rotate the foot and the knee. Sometimes the knee and the foot separately. And so we're just kind of looking at things. We're breaking down the gait cycle. So one thing when I was a student and learning about prosthetics is I had never really thought about what goes into taking a single step and how each part of taking a step can be very, very broken down and highly criticized. And I try not to, overemphasize that to overwhelm people, but I do try to coach them on what they're supposed to feel at different parts of that gait cycle so that they can help with that feedback and say, okay, when I'm swinging my leg through, I'm feeling this. It doesn't feel like my foot's contacting. I'm walking on the outside of my foot or the inside of my foot. And so there's a lot of different ways that prosthetists kind of diagnose alignment issues or kind of see that. There's tools that we can use. Take a lot of videos, slow motion videos, and I come back in the office and I slow them down and rerun them and watch them, especially if there's someone that's struggling to describe it. If they're saying, I don't know, it just feels off, then I'll do that and kind of look at things that way. And you can get very detailed with your alignment, and especially that static alignment phase, putting lasers on and kind of seeing where the weight line is going and dropping it down, kind of centering everything up is super helpful. And so taking the time to really criticize your alignment during that fitting phase. The goal is that you're in a good spot by the time that they get the prosthesis, but again, it's always changing. So.
Okay, we lost you there for a second, but she popped right back on.
I think I need to plug in my laptop. That would probably help. So
go ahead, and that'll give us just enough time to do the next giveaway. By the way, our first giveaway winner is Mary Ann. So Mary Ann, congratulations. We are going to be sending you some very nice Integrum swag. And actually, let me go ahead and just put up my email. Guys, for those of you who are new to the show is for you, the amputee community. So whether you're an amputee, a clinician, a caregiver, or a family member, I want to be able to answer your questions and give you the information you're looking for. So there is my email address. You are more than welcome to email me, and I answer all the questions. Mary Ann, I need you to email me your address so that we can send you your goodies, and we can go ahead and pop up the next giveaway. And with this next one, we have ambassador sign up. So obviously we have Ginny, who is a wonderful example of an Integrum ambassador. But guys, they really do have an amazing team. So here we go. We've had Susan on the show. We've had Glenn on the show. I am hoping to get Nick and Carol on the show at some point as well. But truly, these are really beautiful individuals inside and out. And they have wonderful stories to tell. They're a wealth of knowledge, truly. And they are so open about sharing the ups and downs and the good and the bad and the ugly about what happens life as an amputee, as well as with osseointegration. So again, click on this QR code, and I believe Jamie is going to be putting the link in the chat section for those of you who are having some issues with the QR code. Again, guys, I can see you if you are clicking the QR code, so start clicking that QR code. Fill out that form, and if you want to just chat with an ambassador, even if you're not sure if you're interested in getting OI, if you're just curious and you have questions, fill out this form. And really just some really fun people. If you've ever been to any of the conferences and met any of them, they always have a really fun booth. There's always a party going on right over there. So guys, there's the link right there that Jamie just put up there. So in the meantime, so getting back to it. So Ginny, what are some of the things that you've said, even some of like the crazy, especially the crazy things that you may have said to Scott to just try to describe what's going on with your alignment?
There's a lot of times where I've told him, I feel like my heel is not touching the floor, or I'll tell him that I feel like when I swing through that I'm having some rotation, and really you can't see that. Like I've tried to film myself and look for it, but it's something that I feel. So it's a matter of making a little tiny change just to make that swing through feel smoother. But yeah, it's crazy because sometimes you'll start to gaslight yourself into thinking like, am I really feeling what I think I'm feeling? Because it's not showing up in anything that I'm filming. But Scott always knows what I'm talking about. He's very good.
It's like the translation right there. Scott, what would have been one of the craziest things that someone never told you trying to explain?
I mean, I think something that comes up pretty frequently, especially in someone that's new and is using a socket, is their limbs getting pressure in a way that they've never experienced before. And sometimes some of the nerve pain things that happen, especially early on. So your alignment can definitely kind of affect the pressure inside of the socket. And so I've definitely had people say, when I'm walking, I feel my big toe and it's making it hurt, and I know it's not there. And so some of those phantom sensations or phantom pains can be influenced by pressure and therefore alignment. And so I've definitely had those types of things. And when that comes up, I just reassure them like, hey, I know that sounds crazy. It's super normal. Here's kind of what's going on. Hopefully it will get better with time. And sometimes I do change the alignment if I'm seeing something, and it'll help. They'll say, yes, that feels better. I don't feel that at all anymore. So yeah, I haven't had anyone say anything too crazy about their alignment. They just, most of the time they're like, something's off, figure it out. I need to walk smoother. It's too hard to walk, or my knee's buckling. And it's one of those things that it's a very different process with every patient. So but it's fun. It's a cool thing to go through and then to see. And you make a change and you see that change, and it's like sometimes patients are like, wow, I couldn't have done that with my other leg. Like when we talk about orthotics sometimes and changing that alignment's much harder. And so we do have the option to move things around and change angles and change heights and lengths. And definitely had, bilateral patients, meaning people that use two legs that, some of their goals are just to be taller than their brother, or, and now that they have that and have a prosthesis on two legs, maybe that's an option. Maybe
they can actually get it done. They can actually get it done. So Bill actually asked a really great question. Is change in weight going to affect your alignment?
Again, it depends. Certainly in I think in a socket, we see this a lot more frequently where there's a change in weight or even just the limb starts to atrophy. And so a lot of times that's going to affect your overall height. And so it's not uncommon for a new user with a socket to come in and say, I know we had the height right a month ago, but I feel short. And we measure the length of their limb and their limb has atrophied and it's shorter and we have to add that length back. And so I think in that way, weight can maybe affect it. You're looking at certain things with the componentry. So if you're in a microprocessor knee or foot, you have to program that component to the body weight. And so if someone has lost weight, I always have to go back into the software, update that because it's looking for a certain percentage of their body weight to be on the prosthesis. And so if they're not getting the knee to bend properly, it could be that the settings were for their weight, when they were 30 pounds heavier or lighter. So in that way, it can definitely affect it. I mean, I think, those types of things definitely can affect your alignment. But mostly with sockets, that's going to affect the fit of your socket. And so, we have to definitely look out for those things.
Yeah. And then as far as like the tools that prosthetists use, there's all sorts of fun toys. I started my profession when dinosaurs were walking the earth. So we just had we had our we would look at our patient and just do a visual examination. And now we have lots of wonderful tools. We have laser pointing, and then we still have people like myself that we still go by visual. But let's talk a little bit about, we're going to put a picture of Jenny in the frontal plane. So just standing straight, looking forward, so that we can comment a little bit about what are some of the things that we look for in alignment in someone who's an above the knee amputee. And this also goes for below the knee as well. Bill, osseointegration is actually being used all over the human body. We're seeing it in upper extremity, lower extremity, transtibial. But here in the United States, it is only FDA approved, number one, for the Oprah device and for above the knee amputees. If you're seeing other amputees that have transtibial or below the knee OI, I know Johns Hopkins that just did their first thumb OI. Those are being done through compassionate use. So basically the FDA says, okay, we have not officially approved it, but we've reviewed your case and we're giving you permission to do this surgery. So that's where you might see other parts of the body being done, and also different methods of OI. Oprah is not the only method of osseointegration out there. We did a good show on that about a year ago, explaining the different kinds. Globally, yes. Globally, you are seeing, especially in Europe and in Australia, that they are using osseointegration in different levels of amputation. So good question. All right, so let's take a look at this picture of Jenny, and I have got to get our pictures out of the way. How can I do that? Aha, I did it. Okay. So guys, unfortunately, I was not able to get this picture a little bit larger, but in this picture, Scott is using a laser. And if you look really closely, you can kind of see a faint red line almost going down the middle of Jenny's prosthesis. So you can kind of see it towards the top. You see like a little red line. Can you guys see that? I don't know. It's a little bit of a stretch. That was my fault because I'm not very savvy with graphics. Okay. So I'm going to talk a little bit about what a PT, like what I'm looking at when I see this, and then Scott's going to chime in and tell us his prosthetist point of view. And then I also want to hear from Jenny what she says when she sees her picture like this of her alignment. So one of the first things I look at is to see, are the hips level? Okay. And this is where your friendly PT is going to jab their fingers into your waistline to find those hip bones and make sure that they are level. Okay. And then just kind of moving down, I'm looking at the angle of the femur. Right? Is it going in? Is it going out? Is it going straight down? I'm also looking to see, are the knees even, which it looks really, really good in this picture. Nicely done, Scott. Right? And then we're also looking to see the feet. Are they pigeon-toed? Are they externally rotated, like pointing outwards? Is the person standing like John Wayne, or are they having their feet closer together the way they're supposed to? Right. So Ginny, what do you see from your patient perspective?
Well, it's not awkward at all to stand and pose for these photos.
No, not at all.
I definitely see that everything looks even, but what still strikes me, I don't know why my limb is like this, even after so many revisions, but the shape of my limb is not even at all. And that throws off even my sight sometimes, because it looks like my right leg is sticking off to the side a little bit, but it's not.
Right.
What you have to focus on is where the abutment is coming out, because that is definitely centered inside the femur. So that's what I have to tell people all the time. I know it looks wonky, but I promise you that abutment is in the right place. So that's in the femur. We know that's aligned. You just have to go from there.
Yeah. And it looks really, really good. And again, I can see where some people, if they don't know what they're looking at, they're going to say, well, why is her leg sticking out? It's like, no. And we're going to show you guys this amazing x-ray that's really going to show you what's going on and how good of an alignment this is. We actually have, let's say, Rafaela says, I'm one of the first physiotherapists in South Brazil to do OI rehab, so I still have a lot of questions about alignment. Welcome, Rafaela, tudo bem? She's asking, Scott, how can we correct medial-lateral alignment in osseointegration? So, Rafaela, Scott, do you want to try this one now?
Absolutely. Yeah, the kind of the really cool thing about osseointegration, the first time I remember seeing the first patient with it, when we're looking at a prosthesis with a socket, we're trying to have x-ray vision and see through that socket, through the liner, and try to envision where is that femur inside of there. And we're trying to align those components in relation to wherever that femur is. And so we have a very clear indication with Ginny's limb here where her femur is. And so I can put my laser line on the center of her abutment, and I know exactly where her femur is and align everything in relation to that. So to answer your question, Rafaela, I think there's several ways to correct medial lateral alignment and osseointegration. And some of those are conventional ways of changing angles and making sure that we don't have any sort of leans going on when they are standing and then start to walk. And so there's certain prosthetic components and certain alignment considerations and componentry that we can manipulate to change that. But then there's also the physical therapy side and making sure that there's not a muscle imbalance or a contracture that's going on there and addressing it that way. And both of those can definitely affect the alignment. And what I'm looking at here in this picture too is I'm trying to make sure that basically that prosthesis is looking at me straight as well. And so that's kind of the first place we start with, especially with the axor, which is the connector that Ginny has, is we have to get that in the correct plane before we can really even start to look at her alignment. That abutment that sticks out basically has 4 flat sides to it, and it can be rotated in any direction. And so we have to get that rotation in her line of progression, which is basically the line that she's going to walk, but the prosthesis in correct before we can start making any of those changes, because the angles will not be in the correct plane if you don't have it straight at the top. And so it's a little bit different way of looking at it than with the socket, but we have to get that kind of looking at us in a straight plane first and then make our changes based on that. And really, we're just trying to copy like a normal anatomical alignment. So we're looking at that position of the femur, and we're trying to encourage what's called a varus moment, but a slightly narrow gait so that we can get a good weight shift over the prosthesis. And so, and then the other really important thing, which you kind of alluded to, is height. So we got to make sure the knee centers and the overall height of the prosthesis is correct before we start walking.
Absolutely. And Bill, yes, pin lock does affect your alignment if you don't have the liner lined up. It affects everything, and it really messes everything up. So usually if I have a person who's using a pin lock suspension system and they're just like, I am not comfortable, the first thing I make them do is take everything off, put it back on again, and make sure that pin lock is positioned in the right place. So guys, those of you who've been watching the show, you've heard me talk a lot about stabilization of the femur in the socket, right? And you've seen me demonstrate. So this is just like a traditional socket right here. Okay. how the prosthetist is trying to do what's called a bony lock. Okay. They're basically trying to stabilize your femur, your thigh bone in here. And the best analogy I've ever heard is having a popsicle stick in a cup of Jello and trying to stabilize that popsicle stick, right? That's basically what the prosthetist is trying to do to keep that femur stable and prevent it from swishing around in the socket. Okay. So those of you, especially those of you who are my above the knee users, right? Many of you can probably relate to a time where you have felt pain on the outer side of your socket because your femur was perhaps clapping out to the side. Okay. So that kind of brings me to this really awesome x-ray. It's probably one of my favorite radiographs to put up because I think it just demonstrates beautifully how alignment works. Okay. So guys, if you're looking at the screen, the one on your left, okay, you can see that this is a person wearing a socket. And if you look up, you see that skinny little stick up there, that's their femur. And I want you to notice how the femur is like completely going out to the side. Can you guys see that? Give me a heads up or a thumbs up in the comment section. Can you guys see the femur in that socket? I'm gonna give you guys a minute. Because this is kind of what hits the nail home. So Bill's saying, yep, super cool. All right. So guys, when you're looking at the femur like that, you can imagine that the person is probably feeling a lot of discomfort at the end of the femur because it's slamming into the side of that socket wall. Okay. But if they didn't have the x-ray, that socket looks like it's fitting pretty good, right? And this is kind of part of the challenge of getting good alignment and good socket fit. Okay. And then you look next door, the x-ray right next to it, and obviously this person has osseointegration, right? And you can see how that femur is now been pulled back into place. It is like, it's literally anchored into place, right? So you guys remember what Ginny was saying about her picture, that even though her limb looks like it's kind of poking out to the side, the metal implant is in the right place. The abutment is in the right place. And this is what it's doing for her. It is pulling her femur back in. Do you guys see that? I'm going to leave that up there for another few seconds. So I think this picture really, really demonstrates just what great alignment you can get now. Okay. And this is going to help prevent a lot of the times when people are walking and kind of lurching sideways, that kind of a gait pattern. This helps to correct that. It's bringing that femur back to where it needs to be. All right. Scott, any comments? So Ginny, actually, sorry, Scott, I'm going to interrupt you for just a second. Ginny, did you have any of those issues when you were using a traditional socket? Like, did you feel that femur clapping out to the side?
I definitely did. And I even had sockets where they would like they built channels into the sockets to try to like stabilize my femur in there. But I had so many issues with like redundant soft tissue that it was just impossible to capture that femur within the socket. And it was always swimming around in there. So yeah, it wasn't always comfortable. And I, every week would have to give myself at least one day out of the socket to kind of recover, to be able to stay as active as I wanted to be the rest of the week.
Mm-hmm. Mm-hmm. And then Scott, you still obviously work with a lot of traditional socket patients. So this is something that you're always having to work against.
Yeah, totally. It's a good analogy. The popsicle stick, that's definitely true. And there's a lot of design and research into socket technology to try to figure out a way to control that femur. Some people may be familiar with like the hi-fi interface, and basically what that is, it's creating these big openings in the socket and making the inner volume of it really tight so that you can try to get in there and control the femur. And so that's kind of like what the channels Ginny was talking about. And there's a tolerance to what the skin can handle. So we can't just squeeze the limb as tight as possible because one, that's not comfortable, and two, you're not going to be able to get your leg into the socket fully. And so there's some big challenges with trying to stabilize that femur. And there's some compensations that happen when you're in a socket, and you become reliant on having a socket and having your femur in that position. That's how you've learned how to walk and stabilize yourself. And so it's one of the huge challenges that I've had with osseointegration patients. When I get them in a natural anatomical alignment, they feel like they are in a place they've never been before. And it's overwhelming at first, and they have to really kind of get used to that. And Again, I'll always reiterate this because I do my patients with physical therapists and trying to break those bad habits and teach them to engage the proper muscles to walk is huge and kind of overcoming that. But it's not something that happens quick, and that can be frustrating. So it's another challenge.
No, and we talked a little bit about this in our evolutionary, we called it evolutionary alignment. And I think that kind of says it right there, so, again, using poor old Bob here, if a person, a lot of times people know a lot about the hip flexion contracture, right, where the hip gets stuck up like that. But a lot of people don't realize they can also get what's called an abduction contracture. And it's where basically your hip is being held out this way, right? And the shorter your femur, the higher up your level of amputation, the greater chance you have of developing a contracture like this. So guys, you can imagine if you're using a traditional socket and the prosthetist is trying to get that femur to go in, swimming around in that socket, some challenges. And then conversely, right, if the person is new to osseointegration, they probably have some degree of this kind of a contracture. So a prosthetist, and I guess this is a debate between, I'm sure between you and your colleagues as well, Scott. Do you start your patient off in a gentle alignment, right? And allow the patient to slowly work their way in? Or do you get aggressive with the alignment and say, no, man, we're going to put you in where you need to be right from the get-go and go from there? Like, how do you approach that?
For me, I mean, it's a two-way communication. There's what the patient can tolerate and what feels comfortable and what looks appropriate in terms of the leaning and what they can kind of go home with in a safe way. I definitely lean on the more conservative side. I kind of try to accommodate where they're at and let them kind of progress and change it as they go along. Because if you try to get them in an alignment that they're just not ready for, then sometimes that can just lead to a lot of frustrations, and some people either give up or feel like it didn't work out. And so I try to explain that, like, hey, your alignment's a moving target. We kind of are here now. Let's reassess in a few months. Let's get in contact with your physical therapist and get updates from them and kind of see what they're seeing. And when we need to track your alignment, and it's going to change. So I don't necessarily start them off completely where they're at. Sometimes I do try to encourage a little bit of that natural position, but I don't find that I try to jump exactly to where I think they're going to end up. And a lot of times if someone tries to walk in that alignment, it doesn't look very good, and they're not going to feel like they're walking well either. So that's kind of where I stand on it.
So Ginny, you've had a couple of surgeries since your major OI surgery. And I know that's an understatement. So when you come back from these surgeries, I'm sure you're noticing big changes. So tell us about some of those changes that you noticed.
We made a lot of major changes to my alignment at the beginning of the year. And I think they felt good. They were different the first few steps, but I think overall they were good changes. They were necessary. It was something we had been trending towards little by little anyway. We just put the pedal to the floor and made the big changes. And then a couple of weeks later, I had a major revision surgery to remove some neuromas and do RP&I again. So that made everything super tight. So then when I was cleared to use my prosthesis again, it felt like my knee was trying to buckle as soon as I put weight on it because of how tight I was. So I had to get in touch with Scott. We had to dial back those changes a little bit. And he's really good at saying, if you get home and you realize this isn't where things are, call me, come back, we'll change it. Or I'll walk you through the changes over the phone if you can't get in here right away, because I want you to be safe with whatever you're doing. We dialed things back. And I think in a couple more weeks, I'll be ready to go back to where I was before surgery, but it just takes time to loosen everything up and stretch out again and strengthen things up again as well. Those muscles go away in a hurry and they take a long time to build back up.
And this brings me to a point about one of the biggest differences with OI versus traditional socket is how much more of your muscle you're using with OI. And this is what's actually causing all of these alignment changes. Like we're talking about how often you have to go in for alignment changes, and people are probably just like, well, why is that going to be a good thing? It means that you're getting more range of motion back. It means you're getting more strength back. That's what that means when an osseointegration patient has to keep going in to get their alignment tweaked, because they're gaining all of that back. Guys, when you're in a traditional socket, I mean, it's not to say that traditional sockets are terrible. No, of course, we have lots of people who use traditional sockets and they're very successful in their mobility, okay? But at the end of the day, there's a delay. For example, one of the things is when your foot hits the ground and those forces are transmitted up and your muscles react to it, there's a delay. It has to go through the prosthesis, through the socket, and then it hits your skin and your muscles. Versus osseointegration, your foot hits the ground, that goes right up into your bone and your muscles react almost instantaneously. Okay, so just that alone is going to make these muscles stronger. Okay, and you're also using so much more range of motion, and you have to, because you've taken away the support of the socket. Okay, so that's kind of a big, it's a big change moving to osseointegration.
I will
yes,
also
Jen.
say on that same topic, it means that your recovery might be a little bit longer. Your rehab phase might be a little bit longer with osseointegration versus with a socket, because of your increased range of motion and muscle usage. You're using things in a totally different way. And if you just go full speed ahead, you're going to cause an overuse injury right away and set yourself back guilty several times of doing that. And it's really easy to do that because you've been sitting still for so long and you think, this is great, it feels so much better, I can just put it on and go. But you've got to follow that protocol to set yourself up for success long term.
And then the trade-off is that once you follow that protocol and you get that range and that strength back, you're going. Like, it's incredible. And again, I see probably the biggest impact is in folks who have a very short residual limb, like yourself. Like Mary's another beautiful example of a very short residual limb, where I'm just like, this level of activity with a prosthesis would be very, very, very difficult with a traditional socket. And just keeping that socket on, for crying out loud, to keep that suspension on. And you mentioned that just even with your yoga classes. You know, I don't know how you did it with the socket on in the first place. Okay. I was going to say, I don't even know how that would have even worked, because I
didn't even attempt it. I did it on one leg because there just wasn't a way to keep it on. It wasn't worth taking it in for a couple of poses and then losing it the rest of the time. So I just went on one leg.
Yeah. All right, guys, we're going to do our last giveaway for the evening. And our second winner was, hang on, they're sending it to me, Scott. That's my boy, Scott Hager, right there. So Scott, you know, I know your address. We're good. We're good. So we're going to send you some Integrum swag. Guys, last giveaway of the evening. We're not done yet, though, so don't go away. All right. Start clicking the QR code. Thank you for the person who's already doing that. It's going to take you to Integrum's Facebook page. Guys, this is where I am humbly asking for your support. If you've watched the show, if you like the show, even if you don't like the show, I'm still going to ask you for your support. I keep the support of my sponsors and their generosity. And in turn, sponsors need to have some love too, so that they can continue to provide these resources for the community. And we can show our support in a simple way. Follow them on Facebook. Follow them on Instagram, subscribe to the YouTube channel. So just those little simple acts can really help us a lot in keeping this show going. I feel like I sound like a PBS. You guys are probably too young for those PBS telethons, right? Okay, yeah, I'm feeling old right now. Okay, guys, click on the QR code, follow the folks on Facebook. We're gonna choose a winner from the followers there. I'm gonna leave it on for another minute as we get on to our next question. So we talked a lot about the faster response, you know, that a person with OI will have, Scott. But there was an interesting study, and I don't know if it was Kurt who gave me the statistics or if it was you, that people who use a microprocessor knee, I think it was the C leg, that they're able to utilize more of the features, specifically the stance flexion feature. So guys, those of you who have a microprocessor knee, if you've ever heard of that phrase stance flexion, it basically means when your foot hits the ground, your knee does not have to be perfectly straight. It can be bent a little bit, which is what it's supposed to be, and you won't buckle. Right. So that's one of the hoopy scoopy features in these microprocessor knees. Right. And as an OI, Jenny, do you feel like you use that more? Did you use a microprocessor knee before with your traditional socket?
I did. I've always used a C leg. I have a mechanical knee as my water leg, but yeah, I've always used a C leg. Love the stance flexion feature.
There you go. Did you notice a difference or not really? Or how did you?
I didn't notice a major difference at first. I think I'm using it more now than I did when I had a traditional socket, but
Okay.
Yeah, not a major
And then
difference.
Scott, do you have any kind of experience, or have you seen this in any way?
Yeah, definitely. It's a much broader conversation, kind of talking about a mechanical knee and a microprocessor knee. There are mechanical knees that have the ability to achieve stance flexion.
Right.
With a microprocessor knee, like the C leg, you have the ability to kind of get someone to more consistently engage that stance flexion in a safe way, because it can boost that resistance up and keep them from buckling if they're in an unsafe environment, if they take a misstep, or maybe their alignment needs to be tweaked a little bit. So the C leg is definitely more forgiving, and you'll get stance flexion out of the C leg much quicker for a newer patient, and much more consistently, even for experienced patients. I think with osseointegration, I definitely see that. I see an increase in stance flexion for sure, but more commonly, I see the knee triggering into swing phase, meaning they're hitting the criteria for that knee to bend so that they can swing their leg through a lot quicker. That's something that can take a lot of time for a new patient. And so someone that hasn't walked in a while, I'm usually really shocked by how fast they're able to kind of figure that part of it out. And then once they get that, then the stance flexion is kind of the next thing that we're kind of teaching them to use and not to be afraid of. If someone's been in a knee that doesn't have stance flexion, it's always going to feel a little bit alarming at first. They're putting their heel down on the ground, and as an amputee that's above the knee, that's the scariest part, and that's the most kind of dangerous part. You're the most unstable right at initial contact and loading response when you're putting your weight into that leg, but that's also when that stance flexion happens. And so you have to kind of teach them what that feels like, and repeat it. And there's a lot of exercises, physical therapists too. I try to teach them how to see that stance flexion and to use it, so that you can practice. And then once you can incorporate it into your gait, it's a much more comfortable. It's a shock absorber, so it's a much more comfortable way to walk. And the range of motion that you're kind of available to use with osseointegration is much higher. And then, yes, that feedback is much more enhanced with osseointegration. So I think cueing and kind of learning how to use those features is definitely a bit easier. They can feel it a lot quicker.
No, absolutely. And I was going to say, when I'm teaching my patients, my above the knee patients, probably the part I spend the most time on is getting them to put the weight into that prosthesis and learning how to bend that knee right at that part before they go into swing phase. And that's also where alignment, I can tell if it's aligned properly or not by how much trouble my patient has doing that. So I know if it's a Friday afternoon alignment or a Monday morning alignment. I'm kidding.
No.
All right. Rafaela asks, do you have experience with the 3R80 or just with stance control knees? So Rafaela, yes, I actually cut my teeth. I didn't see my first microprocessor knee until probably 10 years ago. So I spent the first part of my career teaching patients how to walk with mechanical knees, and I love it. I still like it's a lot more challenging, obviously, than a microprocessor knee. But I also think that when a person really masters the use of a mechanical knee, they can really they're very much in control of it. Is there anything in particular that you want to know about the 3R80 or about the mechanical knee, Rafaela? And correct me if I'm wrong, that's a single axis. It's got hydraulics in it.
Yep.
It's a knee. It's a nice knee.
Yeah, it's a rotary hydraulic knee, and so it definitely works a little bit different than a microprocessor knee does. But someone that has a lot of strength and voluntary control over their prosthesis can do really well in a knee like that. And sometimes if someone's in a knee like that and they go to a microprocessor knee, they're like, I don't want to wait on this computer to think, and it's thinking very fast, but they can feel that, and they want to have that kind of like driving an automatic or a manual car.
Yeah.
They want to have that manual control.
No, and that's interesting. Like when the sea legs started trickling down into the general population, I heard those, especially in the younger active folks, that they were like, nope, we like our feeling through the mechanical knee. So it's interesting. Which one do you have, Jenny, for your mechanical knee? Which one do you have, out of curiosity?
It's an Ollie 802. And the only reason I have it is because when I was looking at getting a water leg, my insurance wasn't going to cover that. And so I was actually working at a prosthetics clinic, and I knew a bunch of vendors, and I was able to talk one of them into giving me an ollie at the like retail price or whatever the lowest cost available was. They were able to give it to me at that cost, which was so nice and so helpful. I still spent thousands of dollars on that leg, but
I believe you.
I got it at a better rate.
Yeah, no, I believe you. I believe you. Okay, guys, let's see, Rafael asked, I asked you the high cost here in Brazil of microprocessor knees. I was curious if the results would be good too. Yes, absolutely. And actually, I spent 2 summers, I had a chance to go twice to Guatemala, and everybody there uses a mechanical knee. And the streets of Guatemala are scary, even if you have 2 anatomical legs. So yes, you can be extremely successful using a mechanical knee, Rafaela, for sure. And a lot of it, again, it does go back to, from a PT standpoint, getting your patient as strong as they possibly can, working on proprioception, working on balance. And then from the prosthetist standpoint, the socket fit has to be perfect if they're not an OI patient. And then their alignment also has to give them that advantage, because they're going to really need that alignment to be spot on right there as well. So yeah. Guys, I'm going to put up my email address one more time. Rafaela, if you have any further questions, happy to answer them right there. And guys, for any of you who have any questions, if for whatever reason we missed your question tonight or we didn't get to it, for those of you who are watching the replay, please be sure to put your questions into the comments section as well. All right, guys, we are going to go ahead and wrap it up for this evening. I do want to say a huge thank you to my special guests this evening, Ginny and Scott. Thank you so much for taking the time to be here and to share your stories and your expertise with us. We really appreciate it. And as always, thank you to Integrum. They have been absolutely wonderful with sponsoring this show for a couple of years now, and it's been a joy working with their team, and I've learned so much. And our last winner of the evening is Stephen V. So Stephen, congratulations. Send me your address so we can send you your gift card. All right, guys, as always, thank you for letting us be a part of your lives this evening. I will see you actually tomorrow, because it's Limb Loss Awareness Month, and I'm broadcasting. Oh, have a good month.
Good work.
Thank you for doing that, Cozy. You are a trooper, and you always give us such great information. And I've been looking forward to this for a long time, because I'm always asked about my alignment, height considerations, all of that. So this was a great show, and I really appreciate you doing it. Thank you, Scott, for your time as well.
Yeah, no, thank you. Thank you guys for having me on. This is fun.
All right, guys. So I will see you tomorrow. Same bat time, same bat channel.